My name is Dr. James Park. I'm one of the epileptologists at Hoag Hospital in Newport Beach and Irvine, California. And I'm here to talk to you about Epilepsy 101. So just kind of basic concepts about epilepsy, if you've had your first time seizure, and just kind of generic information about treatment and things like that. And I'll make this informal. You can ask a question anywhere in between. Just raise your hand, let me know if you have something you want to ask me, okay? So what is a seizure and what is epilepsy? A seizure is basically just a sudden kind of surge of abnormal electrical activity in the brain. And depending on where that starts, you can have a variety of symptoms. So your brain controls everything, right? So vision, hearing, emotions. So depending on where that seizure starts and spreads, you may have different symptoms that come about from it. And when that spreads from one little spot, let's say, to the whole brain, that's when people have the very kind of classic or typical seizure that people think about, where you have loss of consciousness with stiffening, shaking. But again, not everyone has that. So again, everyone's seizures are going to be a little bit different. And then how do you diagnose epilepsy then? Epilepsy just means you have an underlying risk for having another seizure. So the International League Against Epilepsy defines it as either two seizures that were separated by more than 24 hours, or you have one seizure and something that suggests you have a higher risk. So some kind of scan or EEG showing some abnormality that would suggest you have a higher risk, or you have an epilepsy syndrome. So these are the younger kind of children or teenagers who have epilepsy and have a certain type of syndrome. So kind of classically, if you think about like juvenile myoclonic epilepsy, those kinds of things, that would also meet the criteria for epilepsy, even again after one seizure. So how about the rest of us then? How is it diagnosed? We get a bunch of tests to sometimes help us support the diagnosis. History is really the most important thing because tests can look normal. MRIs, EEGs, all those things can look normal in epilepsy patients. So really getting a good history and what the seizures are like, how often they've happened, those are going to be the most important things. I've had many patients who have come and seen me with their first time seizure because that was the first one where they had a convulsion. But when you talk to them a little bit more, they say, oh, I've actually been having this feeling over and over for the past few months. And I actually had that feeling right before my convulsion. So then that would suggest, again, that was an aura and that was actually a small seizure still happening, right? And that would then meet criteria for epilepsy as well. So again, seizure can mean a lot of different things. It's not just a convulsion. It can be these small little symptoms as well. And so the history is really key. And videos nowadays with everyone with a cell phone and things, it's really helpful because when families take videos of what exactly happens, we can see what's going on versus just hearing about it, a description of it, right? And everyone who has a seizure usually will get an EEG. That's where they put the electrodes on the head and measure the brain waves. And here's an example of it that's abnormal, where it's showing these kind of repetitive, what we call sharp waves. And that's an indication that there's an irritable part of the brain that is at risk for causing more seizures, right? So if someone had a first-time seizure and we saw this, you would, again, meet criteria for epilepsy. And EEGs can vary from anywhere from 20 minutes, which is a routine EEG, to ambulatory EEGs, which is 24 to 72 hours. And then some people actually get admitted to the hospital for what we call continuous video EEG monitoring. So that's anywhere from a few days to a week even that we do that to try and figure things out. So depending on the history and kind of our suspicion for things, again, we may decide on different types of EEGs based on that. And then the last thing is, again, imaging. Sometimes, again, scans will show some abnormality that will suggest a risk for seizures. And we'll go over kind of some of those things in a bit. Go ahead.
What's because since I got the VNS, I can no longer have the regular MRIs anymore.
Yeah.
So how does the imaging change basically once once I guess you get further into I guess the research?
I mean, sometimes imaging will be limited by stuff like that, but you can still get certain MRIs with that. So, but usually by then you've already had a good quality MRI if you're getting a device and things like that. So, but again, there are other ways to kind of help us. So, again, imaging is just, this is like if you had your first time seizure, what do we do, kind of, right? So. An important part, again, from the history that we get sometimes, or again, the tests, is trying to figure out what type of epilepsy you have. So there are different types of seizures. People will still use the old terms like grand mal, petit mal, those kinds of things. But that actually, the terminology has changed because that became confusing in terms of, everyone would use absence seizures as for instance, as a seizure where people are staring off. But absence is a particular type of seizure where it's what we call generalized type of epilepsy, versus there are people who have focal epilepsies that will also stare off and things too. So again, the International League Against Epilepsy in 2017 kind of reclassified things just to make it more clear cut, because this does affect how we treat things. So there are what we call focal onset seizures. So again, it starts in one little spot, spreads to the whole brain, or from there it may spread to other parts or spread to the whole brain and cause a convulsion, as you can see in kind of the second picture. And then you can have different types of symptoms with it, right? So it's just the focal onset, but different descriptors. And then you have generalized onset, so that's kind of the genetic type of epilepsies. It starts in kind of the deeper part of the brain and spreads to the whole brain all at once. And again, you can have different symptoms with that. And then lastly, sometimes you don't know the exact kind of onset. Based on the history, based on the test, we just don't know. And then lastly, again, unclassified. So this helps us because the treatment is really going to sometimes be different based on the type of epilepsy you have. So there are certain drugs you can't use, or I don't want to say can't use. There are certain drugs that you want to be careful about using in generalized epilepsies because sometimes it can make them worse. And again, with focal epilepsies, other things may, if as we'll go talk about in a little bit, there might be certain types of surgeries that are available for that generalized epilepsies wouldn't. Did I see a hand? No. Okay.
When you said some drugs are not good for people generalized or might not be as effective, can you give an example of something?
The classic example is like carbamazepine or Tegretol or oxcarbazepine or Trileptal is the brand name. These medications are classically thought of as being more narrow spectrum and only for focal epilepsies, right? But that being said, no single epilepsy follows a set of rules. Everyone's a little different. I will tell you, I have seen several patients where they have a very clear-cut generalized epilepsy, but for some reason the narrow spectrum medication does work for them. And they even may have switched to a more broad spectrum medication and actually did worse. So again, while that's kind of a general rule, again, epilepsy doesn't follow any set rules really. Everyone's going to be a little bit different. All right. So what are the causes of seizures? Seizures really can happen at any age, any time. 1 in 26 develop in their lifetime, or develop epilepsy in their lifetime. So there's a lot of different causes. One is genetics, right? So you can have some gene that affects some channel that can cause, makes the neurons more excitable, for instance. This is just a picture of kind of what the channel is made up of or looks like. You can have metabolic causes, so people have like mitochondrial diseases, for instance. These are more in children and things. You can have seizures with those. You can have structural abnormalities. So this is a picture of someone who has what's called like double cortex. Genetically, they have just the cells didn't migrate where they were supposed to, so you have abnormal tissue where it's not supposed to be. but you can also have other things like what's called mesiotemporal sclerosis. So you can see on this side how it's smaller and brighter. So that hippocampus is scarred over, and it's a common cause for temporal lobe seizures. You can have more kind of not necessarily genetic or even kind of things you were born with, but some people can develop what's called an encephalocele. They have a little defect in the skull, and so the brain kind of pouches out into that area, and that can be a cause for seizures. And these are just examples, right? That's what's called a cavernoma. So it's just an abnormal tangle of blood vessels that's there, and that can cause, it can bleed, and it can cause a surrounding area to be irritable. So a lot of different causes. And then as we get older, you know, we have things like strokes, tumors, and such that can also cause seizures. And then lastly, you have, you know, some patients where you don't see anything on the MRI at all. Everything looks normal. You don't have a clear cause. Or, and then lastly, you have what are called non-epileptic seizures, which is kind of a separate category, but it basically means that there's no abnormal electrical activity going on in the brain, but it can really be due to some kind of stressor or trauma in someone's life. And again, the terminology is for what we call psychogenic non-epileptic seizures. And epilepsy patients can actually have both. A certain percentage of patients can actually have both. So sometimes a lot of what we do is trying to figure out what types of seizures, again, patients are having. So again, the prevalence and the toll of epilepsy. So 1 in 26, like I said, will develop epilepsy in their lifetime. So that's about 3.4 million people in the US, and 150,000 new cases each year, about 65 million worldwide. So it's actually not advertised as well as some other diseases, right? Like everyone's aware of breast cancer, everyone's aware of kind of even things like ALS because of all these kind of viral campaigns. Epilepsy is actually very common, but again, for whatever reason, the stigma behind it and things like that, it just hasn't been as well known, which is great why we have events like this to kind of raise awareness, right? So the toll of epilepsy, like I said, annual number of deaths due to epilepsy is comparable to breast cancer, they say. But the years of potential life loss is pretty high because sometimes it's young people, you know, in their 20s and 30s who are passing away. And again, that's many years lost, which is, again, second only to stroke in terms of neurological diseases. And patients with uncontrolled epilepsy have a much higher risk for that, so 2 to 10 times risk. And the more uncontrolled it is, right, medications are not working and things like that, the higher the risk is, as we see here on this kind of little graph. So how do we treat epilepsy? Majority of patients is going to be medications. So thankfully, over the many decades, we've had kind of an explosion in the number of medications that are available to us. You have this kind of exponential growth of what's available. So it means basically just about finding what's right for you. So finding a medication that controls the seizures but also doesn't cause side effects. Because what's the point of taking something if it's making you miserable every day when you have all these other ones available that you can try? And this is just a picture of how all the different drugs work. And this is really more important for us as physicians to know because it's more about this. I take a look at this and I kind of basically think about what are the chances of side effects happening. If I use medications that are acting on the same area, let's say 2 or 3 medications that all work the same way, then the risk of having a side effect is going to be much higher. And so again, we try to sometimes use different mechanisms, different types of medications if possible, just to help minimize that, but also just, again, maybe 2 different things will work a little bit better than, again, just attacking the same mechanism. And then, like I said, there are patients who have seizures that are not being controlled by medication. So If you look at the graph here, basically they did a study where in one center, all the new epilepsy patients were followed. They were started on new medications and seeing how many of them became seizure-free, how many of them needed second medications, third medications, and so forth. What they found is that about half of patients became seizure-free on the first medication. So that's pretty good. And then you take the rest and you try second, third, or even combination of medications, and you get about another 15% or so. So about 2/3 of patients are well controlled with medications. But that means that you have a third that's left where medications were not working. And that's where they came up with the definition of refractory or drug-resistant epilepsy. So it means when you failed 2 or more medications at good doses, so meaning as we get to higher doses, patients are still having seizures, and making sure that the medication was appropriately chosen, as we said, for the type of epilepsy. And that seizures were not due to missing doses, other exacerbating factors, things like that. So again, the patient is taking the medications regularly, not missing doses, despite higher doses, still having seizures. So 2 or more would make you meet criteria for a refractory epilepsy. And what that means is that basically in these studies is that what they showed that is that by that point in time, the likelihood of another medication working becomes less than 5% about. And the more you try, the lower that goes. And they continued on the study into the 2000s. As you can see here, it's 1984 to 1997. They were like, okay, but those are all the older meds. What about all the newer, quote-unquote, better meds? What happened with those? And really, we saw there was no difference. Still about a third of patients who are refractory. So it's not so much about the medication or kind of how they work. It's more about the epilepsy itself, and whatever kind of network is involved makes it so that medication does not work for those patients. So then what do we do for those patients? For a while it was just, you could just keep trying different meds, but we know, again, if it's like 1% chance, you're just kind of spinning your wheels. So what do we do? This is the probability, like I said. Sorry. So refractory epilepsy, again, needs a different type of treatment. So that's where surgery comes into play. So this is just like a quick kind of algorithm for what we typically do. If someone has refractory epilepsy, we bring them in for monitoring to try and figure out where seizures are exactly coming from. We get imaging studies like an MRI. We get neuropsychological testing to test their memory and kind of just general brain functioning to kind of help us figure out where seizures could be coming from, but also seeing how much deficit a patient has from having had seizures over the years. We may get additional testing, things like MEG and SPEC and PET scans. Everyone, again, it's going to be a little bit different in terms of what they're going to need. And in some cases, that's enough to make a decision about what surgery to do. And in other cases, we actually have to implant electrodes into or on top of the brain to try and figure out where seizures are coming from a little bit better. And this picture down here, for instance, is what we call stereo EEG. It's the kind of newer way that we've been doing surgery, or more common way that we're doing surgery now to detect seizures, where you're putting electrodes into the brain versus on top of the brain. And this gives us a better 3D kind of picture of where seizures are coming from versus something that's laying on top. You're only getting the kind of surface of things. And next to it is a robot, for instance, that we use that they're actually here to demonstrate, helps the surgeon to guide where the electrodes are going and really, again, make it as accurate as possible, avoiding things like blood vessels and things like that. And then let's say surgery tried, sometimes people need multiple surgeries and seizures are still occurring. The other options are things like clinical trials in terms of new medications that are coming out or new treatments that are coming out. And lastly, in some patients, we even consider immunotherapy. So some patients have what's called an autoimmune epilepsy. This is a kind of more recognized kind of entity that we as epileptologists are more aware of now too, is that sometimes patients have an antibody or some kind of autoimmune condition that was triggered where it's affecting the brain and causing seizures. So again, in those patients, it's not just going to be seizure medications, but really, again, some kind of therapy to address the immune system. So what exactly is an epileptologist? Go ahead.
You mentioned the autoimmune. Let's say you have other autoimmune diseases.
Mm-hmm.
Would that increase the probability of getting this type of autoimmune epilepsy?
Sure. The question was, if you have an autoimmune disease, does that increase your chance? It does. It's something that we consider or think about, only because, again, if your immune system is prone to doing that, could you then develop an antibody that then causes, again, something like epilepsy or something else? So that being said, it can also occur randomly. So there's some things that we consider in order to that will raise our suspicion of that, and a lot of different tests that we would have to do to try and figure it out. So again, it's pretty rare, but it is something that is recognized more. So I don't know if you've heard of or read the book or seen the movie. It's called Brain on Fire. It's a woman who had what's called NMDA encephalitis. It was a specific antibody that caused seizures in this patient, and it took them a long time to figure it out because back then, again, no one was really aware of this. But now that kind of doctors are more aware of it and testing for it, we send for panels off to labs and things that sometimes come back with things. Even if that's negative, it doesn't 100% rule it out, because what if there's a new antibody that we just didn't discover yet, right? So there's a lot of things that go into that, but again, it is pretty rare. The other type of epilepsies, I would say, are much more common. Yes?
So let me describe. So the epilepsy surgery is just like a deeper way of the EEG or the long-term EEG, or?
So to consider epilepsy surgery, we have to figure out where seizures are coming from and what type of surgery is possible, right? So sometimes that requires us to put electrodes into or on top of the brain to figure that out. And then based on that data, then we decide what's possible, right? So not every surgery is going to be possible in different patients. And really, by trying to figure out where seizures are coming from, that's the best way.
What are the types of surgery, though?
I can go back and see. So it might be something like resection, so cutting out a part of the brain that we think is causing seizures, and can we safely do that? Some people have what's called a corpus callosotomy. This tends to be in children. They get it where you disconnect the two sides of the brain. Younger children sometimes have what's called a hemispherectomy. They take a whole side out, for instance, because let's say it was damaged at birth or before. Newer kind of treatments that we've been doing more and more of is laser ablation. So if there's a small little abnormality like that hippocampal sclerosis that we saw the picture of, sometimes we can just do a minimally invasive surgery to stick a laser in there and ablate the abnormality. And lastly, we have devices or what we call neuromodulation. So we have 3 different devices that we use now to basically stimulate different parts to basically try and desynchronize or stop seizures. So VNS is one that goes in the chest and stimulates the vagus nerve, and that stimulation then that travels back up to the brain to help stop seizures. DBS is something that actually goes into the brain in the deep centers, kind of major relay centers of the brain called the thalamus to try and stop seizures. And then lastly, RNS, which is responsive neurostimulator. We place those electrodes over or into areas that we think are causing seizures, and it actually detects the seizures and stimulates to try and stop it. So again, we have a lot of different things available to us now for surgery. So let's say you had evaluation for surgery like 30 years ago, and they said, oh, you're not a candidate, seizures are coming from both sides of the brain. Now we actually have things that are available to us to be able to treat those seizures. Resection and getting rid of the parts that's causing seizures is really going to be the best way to try and get someone seizure-free. But if that's not possible, the devices, again, are a way to treat seizures that wasn't possible before. So there's a lot of new things I think that are available, and again, if someone had evaluation a long time ago and are still having seizures, it might be worth getting another evaluation.
I had surgery.
Okay.
Where they wire you up and I guess frontal lobe.
Mm-hmm. And everyone's seizure is going to be different, and where you put those electrodes is going to be different for every single patient. That's part of kind of the planning process. So again, what is an epileptologist? I keep throwing that word out there. I'm sure many of you know. It's basically a neurologist who has specialty training in epilepsy. So I spent 2 years of fellowship at Thomas Jefferson doing nothing but this, day in and day out. So planning surgeries, seeing what seizures look like on the intracranial EEGs, just looking at squiggly lines all day long, basically, right? So having those 2 years, I would say, does give you a lot more experience, especially if you were trained at a big epilepsy center, for instance, like Jefferson. You're just going to see more and know more and do more than, let's say, a general neurologist who, again, I'll give you an example for myself. When I was in residency, spent maybe a month or 2 at most doing epilepsy training, right? So you're not going to learn what you need to know about medications and treatment and even surgery in that amount of time. So many general neurologists do treat seizures, and like I said, 2/3 of patients are well controlled with medications, and that's fine. That's very well, most patients can get by with seeing a general neurologist. But I would say if there's, a question about the diagnosis or medications are not working or there's some kind of issue, again, it might be worth seeing an epileptologist for that, which is what I was going to say here. So again, seizures are well controlled, then staying with a general neurologist is fine because you're doing well, right? But if they're not controlled, you're having issues with medications, any question about your diagnosis, that might be something worth seeing. It might be worth seeing an epileptologist for. And then a special category is actually women of childbearing age. So younger women, I would say it's important to see an epilepsy specialist, especially around the time or hopefully before you get pregnant. I've had many women come to me and say, oh yeah, I had my first child, no one raised or changed my medications during that time, which is very bad because we know that once women become pregnant, their epilepsy medication levels can significantly drop during that time because your hormones are changing, your metabolism is changing. For instance, like lamotrigine levels in some patients, I've had to triple or quadruple the dose during pregnancy because it's dropping so much. Again, when that happens, then you're risking a seizure happening. And if seizures in pregnancy are not a good thing, right? You can fall and hurt yourself, can lead to premature labor, all these bad things. So again, we want to make sure seizures are as well controlled as possible before going into trying for pregnancy, but also during the pregnancy, we're closely watching drug levels and things like that, which again, a general neurologist, let's say, may not be aware of, or again, may not know really what to do with medications at that time. So again, women of childbearing age, even if you're well controlled, I would say is a special category. And what are the different levels of epilepsy centers? So the NEC, or National Association of Epilepsy Centers, has kind of 4 levels. Level 4 is really the highest, which Hoag Hospital and also most of the academic centers in the area or throughout the nation are all level 4 centers. It just means that you are able to provide comprehensive care, basically being able to do all the surgeries, all the testing that is needed to kind of treat the most complex cases, and that you're seeing a certain number of patients per year with epilepsy in your center. And then level 3 and level 2 level 3 is really basically similar, but again, they don't maybe see as many patients. And then 2 and 1, again, are your basic kind of if you go to your community hospitals, for instance. And again, why you should consider a level 4 center is, again, the comprehensive care that you get. You get epileptologists, neuropsychologists, neurosurgeons who are specially trained in treating epilepsy. And then we have many of the advanced kind of surgical techniques and monitoring stuff that, again, some hospitals may not have available. And the other part of it is clinical trials. You know, if, let's say, seizures are not being controlled, then these are other options that we have available to us that you wouldn't be able to get at certain centers. And then really the goal is seizure freedom. And seizure freedom means different things to different people, but in my book, I would say it's always, the goal is always 0, right? So the goal is always to get someone to having no seizures. While that may not be 100% possible in every single patient, that's always the goal, and we'll try to get there as you know, best as possible. This is some of the Hoag epilepsy team. This is our surgeon, Dr. Mehta. Dr. Millett is the epileptologist with me, our neuropsychologist. Sheena, our nurse navigator, who handles all the kind of admissions to the hospital and, you know, all the little nitty-gritty details of our team. Yeah, if you have any questions, you can take them. Yes. Sometimes. So the question was, if an aura is a small seizure, does the intracranial electrodes catch that? When you monitor on the scalp, sometimes you might not catch those seizures because they're so small and so focal that the skull, which is a thick piece of bone, kind of filters it out. You may not see an EEG change with those auras. And again, someone's not losing awareness, so it's not spreading enough to be able to be seen. But when you stick an electrode into the brain, right, you're kind of getting rid of that barrier. And so if you put it in the right spot, or at least put enough electrodes into areas that you think are causing seizures, you may be able to catch it. But that's also, again, a question of sampling, right? So you can't spear the whole brain or cover the whole brain with electrodes, because you have to do it as little as possible or as much as possible without causing harm, right? So we come up with a theory about where things are starting or where they may be going, and kind of putting electrodes based on that. And if we're lucky enough, we'll catch some of those auras and see more focal seizures. A lot of times we detect seizures that the patient's not even feeling, right? So, or subclinical seizures. So there are all these different things that, again, electrodes into the brain will help us to figure out better than the electrodes that are just on the outside. Any other questions? Yes?
It is, in your experience, it is normal for epilepsy in adults have ADHD or OCD?
I would say it's common, just because, let's say, like for instance, autism is commonly associated with seizures and things in childhood, and some of those patients are gonna become adults. Mood issues are very common in epilepsy patients in general. So the statistic is that about 30% of patients have some kind of mood issue as well. So depression, anxiety, OCD, those kinds of things. So just like you can have abnormal electrical activity in the brain, you can also have abnormal chemistry of the brain causing some of these mood issues. So it is something that commonly we see and may even initially treat. But when mood issues become a big part of kind of the treatment, we often get our colleagues in psychiatry and psychology and things to help kind of manage things too. And a lot of seizure medications, fortunately, also have some mood stabilizing qualities. So that's how we may sometimes choose a different medication or choose a medication to treat patients. If there is a mood issue along with epilepsy, maybe we try to find one medication to treat both. Again, it really depends on the case, right? If seizures are well controlled, I would say staying with a general neurologist who knows her case and everything is fine. It's really when there's a question about anything that I would say it might be worth seeing an epilepsy specialist for. Yeah. Go ahead.
So like with I guess the mood, like, cause like my psychology is in one area or hospital, and then my neurology is at another. And then so sometimes it's hard for them to, I guess, correlate with what medications work best and what medications I should be on. Because I've been on this one medication for a very long time. I just don't feel, me personally, I don't feel like it's working as best as it can be.
Yeah. And that's just going to be something that your two doctors really have to coordinate, right? Whether it's them having a call together and being like, hey, what are you doing with your seizure meds? What are you doing with the psychiatry meds? Things like that. Sometimes they're going to be wary about changing doses or starting medications that might affect the seizure threshold and things. But there's only certain ones that we really worry about in terms of that. We still, again, these medications are needed, so oftentimes I'm even starting the prescription for like antidepressant medications and things. So again, it's really more going to be about a coordination between the two, because I'm not an expert in psychiatry, so I'm not going to know how to treat certain types of things, and they're not an expert in epilepsy, so they're not going to know what to do. So again, your doctors just need to coordinate together, I think. Yeah. Are they doing more surgery for generalized epilepsy? Okay. They are. So, for instance, generalized epilepsies tend to be better controlled. Let's say, for instance, like the JME, those kinds of epilepsy, for instance, those tend to be better controlled with medications. And then obviously you have the other end of that, what we call symptomatic generalized epilepsies, or the Lennox-Gastaut, the Gervais syndromes, all those kind of more debilitating type of epilepsies where they have, children have developmental delay, lots of seizures, those kinds of things. But there's new medications even that are coming out for that are having some dramatic effects. For instance, like in Gervais syndrome, there's a new medication, fenfluramine, which has worked really well. And then they're starting to use that in even Lennox-Gastaut patients. But let's say if medications are not working, there's always VNS available. That was one option that's been around for decades, right? But they're starting to actually do even using the DBS and RNS devices to try and, again, put it in different areas to see if that helps seizures. So RNS, again, classically we think about, it's starting in this one little focus, we're going to put electrodes in that area. But now they're saying, what if we put it in the thalamus, where, again, typically DBS would go, or again, VNS would affect. But what if we put this other device in the thalamus? And they're actually seeing some good results in at least kind of case reports and things like that. So they're studying that right now, and people, we're doing it in patients. It's just not, we don't have as much data necessarily on it as, let's say, the trials with the RNS device initially. Yes.
So, what if you're with an insurance company that will not let you out to see? So, I really truly think she needs to see a specialist. Because she has like 5 different types of epilepsy now, a ton of medication, and is still having grand mal subject reports nowadays. But they will not let me out. They will not release me.
Like,
and they do not have a specialist.
The insurance doesn't, you mean? Or?
Exactly.
Okay.
It's like Kaiser Northwest will not only let you see their.
Okay.
I mean, they let me talk to.
Yeah.
The type of doctor that you are in California on the phone, but I'm like, that doesn't really help me.
And unfortunately, insurance does hamstring us a lot of times. And I would say sometimes the best way to really get by that is just whenever the open enrollment is, just to switch insurances. I will say I've had Kaiser patients come and see me, even just, let's say, saying I'm going to pay cash to go see one.
That's what I'm wondering,
Yeah.
because I'm literally at that.
Yeah, and there, epilepsy doctors, will see patients that maybe they don't take their insurance and things like that, But then the issue will be, let's say, if something more is needed than just the diagnosis and treatment and things like that, like any kind of test, then insurance is going to play a role too, right? You're not going to be able to order the test that you want at where you want it because Kaiser, let's say, just an example, says, no, you have to get it done here, right? So that does limit things a bit. And so, like I said, I think the best thing sometimes for patients is, if you're able to, is just switching insurances when the time comes.
So have you seen people who have been successfully referred to you by a situation like this?
Yeah, I mean, I've
Have you been able to help?
again, every case is going to be different, so it's hard to say just based on that, right? So,
Well, I'm just tired of suffering for 4 years. I really am.
yeah.
I really feel
I
like
need something.
they
Okay.
don't have that.
Yeah.
If they don't have it, and she's already going to the neurologist,
Yeah.
they have
I mean, I think Kaiser's only epilepsy center is in Northern California, right? That's like a level 4, so that's
they won't even let her go
that's the
there.
limitation. Yeah.
Yeah.
So, like I said, I think if it's something that you need to see, I think it's worth, again, advocating for yourself and seeking. But when it comes time to, again, if there's anything further that needs to be done, that is going to severely limit what we can do. And so, again, sometimes it's just about getting the insurance that will allow you to do those things, right? So that's just an unfortunate kind of consequence of the healthcare system that we're in. Any other questions? Yes?
How much more common is genetic testing for epilepsy becoming more common?
It's becoming more common, especially because it's becoming cheaper and cheaper to do, right? Back in the day, getting this testing would have cost, much more. Now, robots and machines are doing it, and they're doing like quick assays and all of these things. So it's becoming more common, and the pediatric side probably tests for it more than we do. But even as adult epileptologists, we're starting to test some more. What each gene does, however, is not always clear. Like, you'll get the test back and it'll say, oh, these genes came back kind of as a patient having a copy of it, but it's of unclear significance, right? So what to do with that sometimes is not always clear. But again, in certain types of cases, it may be important, like more, if you're suspecting a genetic type of epilepsy, let's say, the testing may be helpful because, let's say, a certain gene comes back and it says you want to avoid certain types of medications in this patient, right? So I'll give you an example. Like, there's a gene called SCN1A where you want to avoid things like what are called sodium channel agents and things like that. So sometimes it's helpful in that sense, again, and we may not send it in every patient, but kind of selectively decide, who would this be helpful in. So, yes?
How common is it to develop epilepsy after a severe illness or a virus?
So the question was, how common is it to develop epilepsy after an illness or virus? I would say it's pretty uncommon, right? So that's, if something like that happened, that's where, again, you may suspect more of maybe an autoimmune type of thing. But even then, again, autoimmune types may come out of the blue. There may not always be a clear trigger. So, and it really depends on where the illness was too, right? If someone had a virus in the brain, had what we call an encephalitis, had swelling and inflammation in the brain because of a viral infection, that would be a higher risk for developing epilepsy than someone who just had the flu, for instance, right? So it's really going to be, again, case by case basis. Yeah.
Like 5 fire syndrome, like that comes kind of after you have that illness. Is that always autoimmune?
Yeah, I mean, what they kind of terms that came about a while ago for all of these things like fires and Norse and all these things, yeah, are now a lot of them being recognized as probably having been autoimmune. And if you test for antibodies, sometimes in these patients something will come back, but not always. Like I said.
Hospitalized with rotavirus, but also had a bunch of swelling on her brain and all this stuff, and she had her first seizure in the hospital, and then it hasn't stopped. So. Yeah.
But again, if there's some kind of abnormality in the brain that happened, that alone can be a reason for seizures. So, if you get inflammation or some kind of damage that happened from the infection, you can have an abnormal area that then becomes more prone to seizures, right? So that it may not be autoimmune, but more because of, again, some damage that happened. Any other questions? Yes.
Different causes of epilepsy. Is there something available for someone that got a stroke in utero and so is lacking portions of their brain?
So this tends to occur, again, surgeries tend to occur in those patients more on the pediatric side, but sometimes we see it in adults too, right? They had cerebral palsy or some injury in utero that causes seizures and the cerebral palsy. And sometimes we do surgeries for those if medications are not working. So, just because that a big chunk of the brain is missing doesn't mean that the other parts that are remaining are normal. Maybe there is an abnormal part or a part there where there's scarring from the stroke, let's say, and that's the reason for the seizures. And if you figure that out or see that on the EEG, you may actually take those portions out if you can. So again, it's case-by-case basis, but we try to figure it out best as we can with all these different tests that we do. Yes?
Is encephalomania popular after having seizures for an extended series of time, I guess?
Encephalomalacia just means scarring or wasting away of the brain because of something. So that can be due to injury, can be due to stroke, can be due to a lot of different things. So, sometimes having lots of seizures and things can also cause, again, atrophy and things of the brain too. So, again, that is kind of a non-specific term, I would say. It's just a finding we see on imaging. Any other questions? Go ahead. I typically check it every month. So what I would do is pre-pregnancy, we talk about, and any young woman, they could be 14 years old, I'll talk about pregnancy because, again, it can happen. So we say pregnancy should be planned, make sure your seizures are as well controlled as possible. We check a baseline level of the drug to see where they're well controlled. And that's where I would shoot for when they do become pregnant. So as soon as they become pregnant, I say, call me so that I can start checking the levels and adjusting things. And typically I will check it monthly and keep adjusting things because, again, we don't want to fall behind in terms of the medication and the drug level. And then maybe later towards pregnancy, if things are have been looking stable, we might check it less. But again, monthly is very typical.
So speaking of that, planning pregnancy, are there certain birth controls that work better with medication or don't mix well with medication?
That's gonna again be based on the actual type of medication you're on and what birth control for. So, for example, topiramate or Topamax at higher doses will affect the birth control. So it won't make it work as well, right? So then the chances of pregnancy are higher, right? So those are things that we kind of keep an eye on. Other medications, again, can affect birth control, and birth control can sometimes affect seizure medication level. So again, those are all interactions to be aware of that your doctor, when they're starting you on the new medications, that they should be aware of. I usually recommend an IUD if someone is going to go with a contraceptive, because it's more local and it's not going to, again, be as effective by, let's say, medications and things. Any other questions? Yeah.
If the person has elevated seizures around the time of their period, then do you feel like it's the right answer to use birth control to try to stop their periods altogether?
Some of the people who specialize in like women and epilepsy will do that. Some people can have what's called catamenial epilepsy, which is just around the time of the period that they have more seizures and things. So by regulating that, then yeah, you may be able to help. Sometimes also just around that period of time, maybe they'll change the dosing of medications or have her take an extra something or other. So again, everyone's going to be a little bit different, but hormonal adjustments, again, with birth control pill may be helpful. Because the theory is that, again, estrogen is pro-seizure and progesterone is anti-seizure. So again, by regulating that, maybe you can help. But again, not everyone's the same. So, all right. So we're approaching 11 o'clock. So I'll take one last question if anyone has one. Go ahead.
Do you feel like you're zeroing in on maybe less trial and error than yes?
No. I wish I had a crystal ball. I would be a billionaire right now, right? No. Unfortunately, treatment is still a lot of trial and error because there's no blood test, there's no scan I can do to tell me what medication, what dose everyone's going to need. I wish I could figure out what combination might work for different patients. It's just about trying things and seeing how it goes. And many patients, you find that right away, and some it's very frustrating because you're just cycling through meds and having side effects or other issues or seizures, and you're just kind of keep going one after another, and that's just unfortunate. But it is the nature of epilepsy. We don't always know what's going to work best for each different patient. All right. Thank you very much. I'll be around if you want to speak.